Hey there, future nurses, and welcome to this explainer. Today, we are going to absolutely master the APGAR score so you can confidently tackle your government board exams and step into that delivery room feeling totally prepared. Whether you're actively prepping for your boards or just looking for a solid clinical refresher, you are definitely in the right place. All right, let's dive right into this. I want you to picture yourself in the delivery room. The mother has just pushed, the baby has just been born, and the clock is literally ticking. You've got to immediately assess this tiny new patient's clinical status and figure out if they need emergency help. But how do you do that quickly, accurately, and in a way every other nurse understands? Well, that is exactly what the APGAR score is for. Here is our roadmap for today's explainer. We'll start with an intro to APGAR scores, break down the APGAR mnemonic itself, learn how to calculate the score, and then decode the meaning behind those numbers. Finally, we'll wrap up with the crucial nursing interventions, plus the limitations and exam traps you need to dodge on test day.
Let's start with part 1, Intro to APGAR Scores, and lay down our foundation.
So, fun fact, before 1952, there really wasn't a unified way to quickly check on a newborn's condition. It was kind of just guesswork. But that all changed thanks to Dr. Virginia APGAR. She was an anesthesiologist at Columbia University, and she created this incredibly simple yet totally game-changing scoring system. Her main goal? To give healthcare teams a super fast way to communicate a neonate's overall condition and see how they were responding to resuscitation right after delivery. It works so perfectly that today it remains the absolute gold standard for neonatal assessment.
Moving right along to Section 2, the APGAR mnemonic.
Here's what's actually super cool. Dr. APGAR's own last name became the ultimate memory tool for nurses everywhere. You definitely need to memorize this backronym for your exams. APGAR. A is for appearance, which looks at the baby's skin color. P is pulse, checking their heart rate. G stands for Grimace, which evaluates reflex irritability, like how do they respond to being stimulated. The second A is activity, measuring muscle tone, and R is respiration, or their breathing effort. These are the 5 specific vital signs we're looking at to spot any poor blood flow or oxygenation. Now for Section 3, calculating the score. Let's get into the real meat of your exam material and see how we turn these signs into actual numbers.
For each of the 5 categories, you're handing out a 0, a 1, or a 2. Let's start with pulse, which, by the way, is the absolute most critical part of the score when deciding if you need to resuscitate. No heartbeat? That's a 0. Less than 100 beats per minute is a 1, and over 100 is a perfect 2. For activity, a limp, floppy baby gets a 0. A little bit of arm or leg flexion gets a 1, and active, squirming motion gets a 2. For grimace, no response to stimulation is 0. A weak little grimace is a 1, and a really vigorous cry, cough, or sneeze gets the full 2 points.
Continuing with our list, we have appearance and respiration. For breathing, no effort gets a 0. Weak, irregular, or gasping breaths get a 1. A robust, strong cry gets a 2. Now pay super close attention to appearance, because this is where a lot of students get tripped up. A totally pale or blue baby gets a 0. But notice that a score of 1 means the body is nice and pink, but those little hands and feet are blue. We call that acrocyanosis. To get a 2, the baby has to be completely pink head to toe.
When you're out there on the hospital floor, you're going to see documentation charts that stack these categories up just like this. You'll quickly tally the numbers to get a total score out of 10 in real time, literally watching the baby while listening to their heart and lungs with your stethoscope.
Now listen closely, because time-based questions are classic nursing board fodder. You always score the baby at exactly 1 minute after birth, and then again at 5 minutes. But it doesn't stop there. If that 5-minute score is below a 7, or if the baby requires active resuscitation, the guidelines say you've got to keep scoring them every 5 minutes all the way up to 20 minutes, so you can track how they're responding to your help.
Okay, let's hit Section 4, meaning behind the numbers. We did the math, but what do these numbers actually mean for our patient?
Basically, the total score tells you exactly how well the baby is transitioning to life outside the womb. A score of 7 to 10 at the 5-minute mark? Beautiful. The baby is adapting wonderfully, and routine care is all they need. A score of 4 to 6 is moderately abnormal, meaning you better keep a really close eye on them. But a 0 to 3? Guys, that is a dire emergency. It points to severe hemodynamic compromise and means you need to start immediate aggressive resuscitation right that second.
Here's a really interesting tidbit. A perfect score of 10 is actually super rare in those first few moments of life. Why? Remember that appearance category we just talked about? Peripheral cyanosis, those blue hands and feet, is completely normal for a newborn in their first 24 hours. Because of this, it's incredibly common for perfectly healthy, screaming babies to just get a 1 in appearance. So an overall score of 9 is way more common than a perfect 10.
Moving to Section 5, Crucial Nursing Interventions. Let's transition from assessment to action. This is exactly what your exams will test you on. If your patient scores below a 7, you have to act. For moderately low scores, you might just need to vigorously dry the infant to stimulate them, or maybe deliver some oxygen with a mask. But if that score hits 3 or less, you are immediately calling a code blue, informing the clinician, and jumping straight into major respiratory and cardiac support. You should also start prepping the parents for the likelihood that their baby is heading to the NICU for much closer monitoring.
Finally, Section 6, Limitations and Exam Traps. Don't let the test makers fool you.
I cannot stress this enough. This is arguably the most important takeaway in this entire explainer. Never, ever delay giving a baby life-saving breaths or chest compressions just because you're waiting for the clock to hit that 1-minute mark so you can calculate an APGAR score. If a baby comes out limp, blue, and pulseless, you start resuscitating instantly. Clinical care always takes precedence over doing the math for a score. Furthermore, remember that the APGAR score is just a quick snapshot in time, and it definitely has its limitations. For one, it's a bit subjective. 2 different nurses might score the exact same baby a point differently. Also, a healthy premature infant might score low just because their muscle tone and physiology are immature, not because they're oxygen deprived. Things like maternal anesthesia can also temporarily tank the baby's score. And lastly, while a persistently low score is definitely scary, the APGAR alone does not diagnose asphyxia, and it certainly doesn't guarantee long-term issues like cerebral palsy. Let's wrap this all up with a quick pop quiz to test your readiness. Imagine your neonate has a heart rate of 90, irregular breathing, flex limbs, grimaces when suctioned, and a pink body with blue hands. That is exactly 1 point in every single category, giving you a total APGAR score of 5. Since that's moderately abnormal, your very next nurse in action is to stimulate that baby, provide oxygen, and monitor them like a hawk for the 5-minute mark. But I'll leave you with this to think about. If a low APGAR score doesn't definitively predict long-term issues like cerebral palsy, what other crucial assessments will this vulnerable little patient need in their first 24 hours of life? Keep studying hard, you've got this, and best of luck on your nursing exams.